Tell us how to cure pancreas cancer.
Dear Chairman, dear John, dear audience, first of all, I want to, or Jens Werner wants to apologize that he can't be here giving this talk. When he asked me to take the talk, he told me, oh, you have a talk about surgery and pancreatic cancer. When I went into the program and I saw, why is there so little chance for cure in early pancreatic cancer? I thought, what the heck? This is exactly what a surgeon wants to talk about. When you tell a surgeon whatever he does, it's not worth it. Why am I here for? So I thought, okay, the oncologists, they want to challenge me a little bit, and let's see. Whenever you don't know what to look for, cure and early pancreatic cancer, what is this? You nowadays go into guidelines or into Wikipedia, and I thought, a cure is the end of a medical condition, the substance or procedure that ends the medical condition, such as a medication, a surgical operation, okay, surgery is involved, and a change in lifestyle, and so on and so on. Does not help really in this matter. The Merriam-Webster Medical Dictionary, recovery from a disease, also remission of signs of symptoms of a disease, especially during a prolonged period of observation, a 5-year cure of cancer. Now, there we are. I found something, a 5-year survival rate. That's cure in pancreatic cancer. That's fair. And what is an early pancreatic cancer? That's not defined. The only publication I found is an early pancreatic cancer may be defined as one that is still localized, has not spread to distant sites, and for which cure is more likely because it can be excised completely. Okay? Surgery is in again. So that's what we saw earlier in the session already, the incidence and the mortality rates of pancreatic cancer. And when you compare these two data here, 22,000, 19,000, that's about the same. So that means everybody who develops pancreatic cancer will die. So is this a surgical disease? There are some, they say it's always non-resectable. And like Good Johnson's conclusions, after adjusting for calculations and duplications, the total number of 5-year survivors can hardly be more than 700 to 800. Is there the nihilism justified? Is that really true in our days? Lilimo investigated more than 1,000 patients in the years 1970 to 2010, and we got 2, 5, and 10-year survivors from 40% to at least 5 to 15%, 10-year survivors. The 5-year survivors, 15 to 25%. That's what we all know about. And how did it develop throughout the last 4 centuries? We started here bad in the 1970s, but the prognosis, it improved. The last century, the last decade, maybe not that much, but we got much better. From our Heidelberg group, we analyzed 1,000 patients resected all with pancreatic cancer in this millennium, between 2001 and 2009. And we analyzed the prognostic parameters, patient tumor and resection characteristics. And in the univariate analysis, we found a lot of things that you all know. Age as a score, the tumor markers, preoperative insulin-dependent diabetes mellitus. We heard about this before in the session. The tumor staging and grading, the lymph node ratio, and the resection margin. The multivariate predictors, age, insulin-dependent diabetes, CA99 larger than 400, the tumor staging and grading, the R1 status, and the lymph node ratio. And when you develop a risk score out of this with positive and negative signs, like negative is the T1 status or the R0 grading, you develop a prognostic characterization of groups of the entire cohort, where you can divide well between those patients who do really good, 5-year survival rate of more than 50%, and those who perform badly. This is according to the AGCC or UCCC staging, and we think this divides the groups a little bit better. But the most interesting thing is when you go, for example, in the most relevant group, the stage 2B, the patient with a T3 and nodal positive tumor. This is a set of 550 patients. You have patients with a 5-year survival rate of about 60%. And even in those, the largest group of 17.6%. So we found risk factors that allow an accurate prognostication, and the 5-year survival rate is not that bad. But what is the role of surgery in pancreatic cancer, in early pancreatic cancer? This was a topic. There is not much data that compares surgery with other treatments. This is the only randomized controlled trial, and it had to be terminated early because the data in patients for resectable, locally invasive pancreatic cancer, the radiochemotherapy did significantly worse than surgery, and so the trial had to be stopped after interim analysis. This is probably one of the most interesting data from the National Cancer Database, America. Almost 10,000 patients in the years 95 to 2004. So quite new data. And you see, for the patients with stage 1 pancreatic cancer, about 35 to 40% were not offered surgery for stage 1 cancer. These are the ones who underwent surgery. There are some who had, but there are not too many, severe comorbidities, and there are some who refused surgery. And what was their outcome? The 5-year survival rate of those who were not offered surgery, 3% 5-year survival rate in stage 1 cancer. If they underwent surgery, 25%. So I think it is obvious that surgery has the cornerstone to improve survival in early pancreatic cancer, because those ones, stage 1, is not that much better when they not undergo surgery than the stage 3 or 4 pancreatic cancer. And when they looked into the reasons why they did not undergo surgery, they found in 50%, 51.7%, did not have an identifiable reason for not undergoing potentially curative resection, because there was a low experience in the center, a low volume provider, there was no pancreatic surgeon involved, and there was fear of surgery or patient refused surgery because maybe they were informed wrongly. Surgery is not by itself. Yeah? It always needs to be embedded in multidisciplinary treatment. And we know first from the ASPECT trial that surgery, the outcome after surgery is improved when you add chemotherapy. And it was confirmed by the CONCO-1 trial, and probably adjuvant chemotherapy improves the survival by influencing tumor biology. Again, the ASPECT data now in comparison to the CAPRI data. That's a study. Mainly, it was a multi-center study, but mainly patients from the Heidelberg area, where we did immunochemoradiotherapy. And when you see the chemotherapy with 5FU had a median survival of 20% in the ASPECT trial. The chemotherapy with 5FU had a median survival of 28.5 months in the Heidelberg, in the CAPRI trial. And this could not be improved by a very intense chemoimmunotherapy, including radiotherapy. So, but what does this show? With good surgery, with qualitative oncologic good surgery, you can improve the median survival to about 30 months in these patients. So the oncologic pancreatic surgery is the most relevant for prognosis. Sure, we know not all the pancreatic tumors are resectable, and we will hear later in one of the next sessions about the resectables, the intermediate, the borderline resectable, the locally advanced unresectable, and the clearly unresectable because of distant metastasis. But the most important thing when patients undergo resection is to achieve an R1 resection. From the earlier studies, ASPECT trials, there was always no difference in survival between R0 and R1 resection. But this was mainly based on the type of pathology or of pathology of the cancer, of the tumor specimens they got or they looked at. When we have a redefining of the R1 resection in pancreatic cancer, first from the London group, where they said tumor closer than 1 millimeter to the resection margin. And when they look at the specimen in a three-dimensional setting, they found there is a difference. And then this was a major publication that most pancreatic cancer resections are R1. More than 70% by exactly the same technique of resection are suddenly R1 when you look differently. And suddenly you get a difference between R1 and R0. This is from the large group I showed you before, 1,000 patients. You have a clear difference between R0 and R1 resections and the R2 resections, more than 1,000 patients, and it doesn't matter, is this a pancreatic head, a total pancreatectomy, or left pancreatectomy that got resected. And a very new data I just got from a former colleague, from Olli Strobel. They looked at this in 500 patients, 2006 to 2012, and they could confirm this, that the true R0 is much better than the R0, where you have in between 1 millimeter tumor to the resection margin and to the R1 direct, the old R1 definition. And so the true R1s, they perform really good with a median survival of 41 months and a 5-year survival rate of 37% in a quite big cohort of 560 patients. And therefore also the S3 guidelines, they tell you that non-dependent on the location of the tumor, R0 resection has always to be achieved or should be achieved. And surgeons, they worked hard on to get these R0 resections. There are multiple ways a surgeon handles a tumor, how you approach a tumor intraoperatively. You first, by the artery first approach, you exclude that the artery, the SMA or the celiac trunk is involved to prevent the R2 resections. Or there is an Untitled first or Untitled process first procedure where you approach the tumor from the caudal part, you do a retrograde resection to get optimal vascular control of the portal vein and the AMS, and do a radical dissection, what you call the mesopancreas, where all the lymph nodes and the nerves are in, where you have the perineural progression of the tumor. And you see here in these slides, you get a very nice clearance of the soft tissue from the SMA and from the portal vein. You can do a portal vein resection here when the tumor is attached to the portal vein, and this always under good control where you don't have to fear complications of it. Before we heard also a little bit about the lymph dissection. That's a really extended lymph dissection that always needs to be performed in oncologic surgery. Adequate clearance of the lymph drainage. Does it have to be really extensive? There are multiple trials, I think 4 or 5, and the really extensive lymph node dissection does not help. Does give you a little bit more morbidity, but a well-defined standard lymphadenectomy, and a well-defined standard lymphadenectomy, that's clearance in the head tumors of all these lymph nodes, but not the interorthocaval lymph nodes, or in the left side also all these lymph nodes here. Thereby you get the best control of the tumor. But it's not only the very small localized tumor we can approach by surgery, also going further to extended resections where we perform the standard operation plus vessel resection, mainly the portal vein, the superior mesenteric vein, but also arteries, a little bit more controversial, or additional organs like the colon, the small bowel, the kidney, the adrenal glands. They can well be performed, and the ESGPS, the International Study Group of Pancreatic Surgery, have set up a standard definition that you can compare the results from different centers. And This is just handed in for publication or in British Journal of Surgery. More than or about 500 patients with extended surgery, extended pancreatectomy, they do perform a little bit worse than the standard resection because the tumor is more progressed. But still, we have in these patients an 18-month median survival and an 11.75 year survival rate. That's much more better than you can achieve with just palliative therapy, with the best palliative therapy available. That's FOLFIRINOX, where you get only 11.1 months. Sure, they are not completely comparable because there you have more metastasized disease, but extended resections, don't be afraid of. Like here, total pancreatectomy. If no vascular involvement is present, you get a median survival up to 28.6 months and 5-year survival rates of 25% about. Sure, when the tumor is more progressed and the vessels have to be resected, it's a little bit less. But important, you don't have to fear the problems with quality of life or insulin-dependent diabetes mellitus, but because even in patients with total pancreatectomy with a good insulin formulations, probably we will hear later on about, you get good quality of life and good control of diabetes mellitus. The important thing, you have to clear the tumor completely and perform an R0 resection. Getting back to the title again, true early carcinomas. What's this? And precursor lesions, how can you prevent it or how can you approach them by early treatment? Marco Brino told us before the IPMNs, that's the precursor lesion. This is the most, and the IPMN is the most relevant cystic pancreatic neoplasia because it's the most often where we see them, and we heard about the adenoma carcinoma sequence. We know that the IPMNs, carcinomas, perform better than the ductal cell, the pancreatic ductal adenocarcinomas. Here, the IPMNs, here the ductal cell, the pancreatic adenocarcinomas from a large cohort, or here in the multi-center analysis. But we know this because there are more early stages, T1 tumors, T2 tumors, N0 lymph nodes. They perform better than the according groups of the pancreatic ductal cell carcinoma, but when you have a more progressed stage, there is no difference anymore. So what we need, you have to treat them or you have to resect them early. You have to find them early to get the best results. And here you see 5-year survival rates of about 60 to 50%. That's much better than what we know from ductal cell carcinoma. And you can go further. You know this, probably you heard it yesterday. There are different types of carcinomas that develop from these IPMNs, the colloid and the tubular type, and the colloid type does better, but most of the times we don't know it preoperatively, we just know it after specimen retrieval and look at it by pathology. But what we have, we can approach these tumors, these precursor lesions, by very localized surgery with a very low mortality rate, with a very low morbidity, with a good organ functioning, preserving resections, and this is by enucleation of these precursor lesions. We don't know much about it yet, it has to prove in the future, but we know that these patients can be well treated by these local excisions of precursor lesions. Sure, they have to follow up, they have to be followed up early and for the next time, because they can develop tumors in the other parts of the pancreas. But where you are in is always watch and wait, not until carcinoma is developed. You should get into these patients earlier versus a prophylactic resection where you may have some morbidity but mortality, but I showed you, don't fear this because the surgical results are good. The future, I don't have to get into this, we heard it before, and so what I wanted to show you with this talk is that when you operate timely, when you provide timely surgical therapy, when you perform a radical tumor resection, when you can perform extended resection when necessary, or the resect or precursor lesion always in combination with other therapy, multimodality therapy, then the prognosis is not bad at all in pancreatic cancer, and I thank you for the attention.